Thank you, Rusty, for kind introduction of me. As he mentioned, I have close contact with the people in Gajamada University. And it was 30 years ago when I first came here. So compared to the current situation of Jogjakarta, at that time, it's very old city. And I felt that I'm in the very ancient city. But now I realize that you are very advanced stage of the world. So maybe I hope you can understand my presentation. But before coming here, Rusty requested me to give the talk on this title, Advances and Current Issues in Genetic Diagnosis and Therapy in Neuromuscular Diseases. So, and I support. By this title, I must give the talk on the most advanced stage of the treatment. But yesterday I realized you are undergraduate. So my talk is too difficult for you. So I changed the content. So please understand me what I want to say there. Anyway, this slide shows the campus of my university. So it's a daytime picture, and in nighttime, this completely differ to this one. So this map shows the location of Kobe in Japan. So Kobe is located in the center of Japan and facing to the sea. And in Kobe, we have a big port. And from the all the time, we have a connection with the foreign countries. So in that spirit, we have a tight connection with Gajamada University. And as Rusty introduced, I got the Doctor Honors Course degree from Gajamada University in 2003. It's very honor for me. And last year, here in Jogjakarta, my student celebrated as for my 70th birthday. So this doll shows my student and me. There are so many students from Indonesia. And the most favorite food in Jogjakarta for me is ayam goreng, especially in ayam goreng salty. So they celebrated my birthday at that restaurant last year. So this is the introduction of me. And at first, I continue to introduce what is the Kobe city. As I mentioned, Kobe city has a big port. And it's famous for Kobe beef. This is very delicious. This is one of the shopping center in Kobe City. So when you come to Kobe, you can enjoy nightlife. That's all. I'm sorry, that's all. Okay. So please come to Kobe and have very delicious Kobe beef. Yeah. Next one. So next, please show. From now on, please understand what I'm talking about. So what? What is this? Very small. Okay. From the beginning, please start. Please see what he's doing. Okay. Please remember this is Gowers sign. It's called Gowers sign. So this is an important clinical sign to show muscle weakness. So if a patient shows that standing up style, you must consider the patient is suffering from some muscle weakness. That's very important. And every patient of Duchenne muscular dystrophy shows this sign. So if you see this sign in the patient, you must go to the differential diagnosis, considering at first the DMD patient. But next slide, please. This slide shows the list of diseases showing the Gowers sign. So the most common one here is Duchenne muscular dystrophy. 40% of patients suffer from Duchenne muscular dystrophy. This is the most common one. In others, there are so many, but the incidence is not so high. But please remember, in addition to DMD, other muscular dystrophy or muscular disease, patients show this Gowers sign. For example, congenital muscular dystrophy, unknown muscular dystrophy, congenital myopathy, and so on. So it is very rare to see the name of the genetic disease. But please remember, there are so many genetic diseases. Today, please remember that I would like to talk about the Duchenne muscular dystrophy and one more, Becker muscular dystrophy. There are similar name, but different, show the different phenotype. Anyway, please remember the name of Duchenne and Becker muscular dystrophies. Okay. So if you identify the Gowers sign in the patient, we do the differential diagnosis of diseases. Right? The most important is the Duchenne muscular dystrophy. So to identify the clinical Gowers sign, it's easy. Everybody can easily see what's the phenotype. So when they stand up, they need the help of hand to stand up because of the muscle weakness. Please remember that point. So from now on, I would like to explain what is Duchenne muscular dystrophy. As I mentioned, this is the most common inherited muscular disease in the world. Even here in Indonesia, this is the most common one. So this is characterized by muscle weakness with infantile onset. But please remember, as I later explained, at birth, they are normal. Later on, they show the muscle weakness. Infantile onset is the characteristic of DMD. And once muscle weakness appears, muscle wasting continue progressively. So, progress muscle wasting disease. And the incidence is shown here, affecting one in every 3,500 males. Males, only male affect, not the female. So if you identify Gowers sign in male, please consider possibility of Duchenne muscular dystrophy. When you identify Gowers sign in female, the possibility is low, but possible. So this disease is caused by mutation in the DMD gene, the genetic disease. And because of this mutation, all patients show dystrophin deficiency. Dystrophin is the name of the protein in the muscle. And because of the progressive muscle wasting, every patient die early, premature death. So this is this slide show the characteristics of DMD patient. But at last, I must add one more sentence. That is important. Currently, no effective treatment is available. So that's why I'm going to establish the treatment. So because of this, most of the patients die around before 30. Yesterday, we had a meeting in the Gajamada Academic Hospital on the DMD patient. But based on the data, most of DMD patients in Indonesia dies around 20. Many die before 20s. But in the world, nearly it's 30. So 10 years difference are present between the most advanced country and Indonesia. So it's necessary to support the DMD patient to elongate their lifetime. It's possible. As I mentioned, there is no drug. Only supportive care is necessary to elongate the lifetime of the DMD patient. So it can be done even in Indonesia now. So this disease was reported by Dr. Duchenne. Then the name is named as Duchenne muscular dystrophy. So it was more than 100 years ago. And at that time, he reported the article about our progressive muscular disease and described the patient figure as shown here. So this figure shows very accurate point. So those patient must be male. This is male. And here, see here, what's the difference from you then? So these patients show muscle weakness. However, if you see the muscle is very big, not small, very big. But muscle power is weak. So this is so-called should muscle hypertrophy. Should, not real one. And because of the muscle weakness, a patient show the lordosis to maintain the standard position. So this slide shows very typical figure of Duchenne muscular dystrophy patient. And this slide is taken from the wall painting in ancient Egypt. but I hope you can see this kind of wall painting obtained from ancient Egypt. So, what I'm going to say that in this ancient Egypt, we can identify the patient of Duchenne muscular dystrophy because, as I mentioned, in 1868, Dr. Duchenne reported this progress muscle weakness, progress muscle wasting disease, as shown here. So these are male and show lordosis and shoulder hypertrophy. But when compare this man with this one, there are common finding. So we conclude that this male should be Duchenne muscular dystrophy. So in another point, please remember that, as I mentioned, almost all these patients die before 20 in the ancient time. So no one can have a child, but still we have many patients. If it's purely inherited disease, no one will be born with holding a mutation because the patient doesn't have any child. But we still have, because the new mutation is incorporated so everyone can have a chance to have a child with Duchenne muscular dystrophy, even though there is no family history in your pedigree, because a new mutation occurs spontaneous. So we have in the history we already have the problem of Duchenne muscular dystrophy. So I just showed you the change of Duchenne muscular dystrophy by age. As I mentioned, they are very normal in early life. So in this picture, I show the brothers. So when the elder brother was 5 years old, he showed muscle weakness. And other people say that this is not normal. Please go to the hospital. And in the hospital, he was diagnosed as Duchenne muscular dystrophy. At that time, we identified the younger brother. He was 3 years old at that time, but he was completely normal when we see their activity. So that means that until 3 years, you cannot diagnose DMD. After that, around 5 years old, we can notice the abnormality in muscle weakness. Once the patient diagnosed as DMD, as I mentioned, the muscle weakness progress. And finally, all patients are wheelchair bound, lose ambulation before age 12 years old. This is the definition of DMD. All DMD patients lose ability to walk, independent walking until the age of 12. So even though they are wheelchair bound, muscle weakness progress, muscle wasting progress, and finally they lose the ability to respirate. So they need ventilator support when they lose the ventilation ability. But as shown here, when the patient has a respiratory problem, we can support by putting the ventilator on. But if patient show the abnormality in cardiac muscle is also muscle. So cardiac muscle is affected. That we call that the cardiomyopathy. If cardiomyopathy is complicated, there is no way for the treatment. So most of the patients die because of the cardiomyopathy, not respiratory failure. Respiratory failure can be treated. But at this moment, I think that in Indonesia, many patients die from respiratory failure, not due to cardiomyopathy, because not enough care is applied to the DMD patients. So this is the natural cause of DMD patient. And before 30, almost all patients die. But in Japan, at this moment, many patients survive more than 40 years old. So the goal should be there to elongate the lifetime more than 40 years old. So clinically, you should examine the serum creatine kinase when you see the Gowers sign. As I mentioned, the Gowers sign indicates the muscle weakness. So if muscle is affected, creatine kinase should be high. So every patient showing Gowers sign should be examined for serum creatine kinase. So this slide shows the natural change of serum creatine kinase in DMD patients. In their younger age, as I mentioned, they are very healthy, looks healthy. But if we examine their serum creatine level, it's strongly elevated. So normal serum creatine kinase level should be here, around 200 units per liter. So here is normal level. So in the younger time, serum creatine level is more than 100 times higher than the normal. So if we find the patient show the strongly elevate the creatine kinase, the diagnosis would be DMD. And as shown here, these are the serum creatine kinase level decrease along with the progression of the disease. So in the usual clinical chemical test, when the level decrease, it means that this is becoming good. But in the case of the DMD, this decrease indicates the progression of the disease. So this is quite different from other diseases. So for the long time, both Gowers sign positive and high creatine kinase level are indication of DMD. So if we identify both findings in the male patient, we clinically diagnose this DMD patient. Just clinical. But as shown before, there are many heterogeneous geneity of the Gowers positive patient. So we must diagnose DMD properly. For that, it's necessary to identify the DMD gene. So this was the DMD gene is a responsible gene for Duchenne muscular dystrophy. And this was identified in 1987. More than 30 years ago, the gene is cloned. But the most characteristic point is that the DM gene is the most largest gene in human. It spans 2.4 kb on the X chromosome and consists of 79 exons. However, the protein coding region, named as cDNA, is only 14 kb, but consists of 79 exons. This means intron, that is not used for the protein coding. Intron length is very huge. So intron occupies more than 99% of the gene. So that's the characteristic of the DMD gene. And the size of intron is so huge, then naturally mutation will be induced in intron sequence. So from this slide, please remember the number of exons. Exons means the protein coding region. So protein coding region is divided into the 79 parts. And by identifying that this responsive gene, we can identify the responsive mutation in every DMD patient. This slide shows the spectrum of mutation identified in the here I describe this DMD gene same. So please remember that the most common mutation identified in this DMD gene is deletion of one or more exons. So nearly 60% of the patients have exon deletion. The exon disappear from the gene. That's the most common one. And the pattern of mutation differ from other genetic disease. In other genetic disease, most of the mutation are nonsense mutation or small deletion insertion mutation. To see this one, we need the sequencing of the gene. But in the case of DMD, we just need to identify exon deletion. But for this, it's very simple to identify mutation in the case. Anyway, please remember, exon deletion is the most common mutation in the DMD gene. Another point, please remember. So there are so many you should remember. So this line indicates the number of exons. So this line indicated the deleted gene identified in patient. For example, this case has a deletion from somewhere in intron 10s to 50s. So that this patient has a big deletion, but this case has only one exon deletion. So this slide shows that many variety of patterns of exon deletion. It differs from patient to patient. Another point I would like to stress in this slide is that there are two colors of lines, red line and blue line. In red line, I show the pattern of exon deletion identified in DMD patient. From there, I say DMD patient. In contrast, blue line indicate mutation that identifies Becker muscular dystrophy. Becker. I have said that there are two types of muscular dystrophy, Duchenne and Becker. So in Becker muscular dystrophy, we identify exon deletion as shown here. But important point is here. This one, Becker. This one, from Duchenne. So the difference between Duchenne and Becker comes from the size of deleted exon. So both Duchenne and Becker mixed up. Why this mixing occurred? This is a point to understand the therapy. Anyway, there are so many patterns of exon deletion in the DMD gene. This data summarize the mutation analysis of the DMD gene. And DMD gene encodes protein named dystrophin. So dystrophin is localized to the muscle membrane of skeletal muscle. Membrane of muscle, skeletal muscle. So monoclonal antibody against dystrophin detects, show the signal along the muscle membrane. Every muscle fiber shows a positive sign of dystrophy. This is normal. But in the case of DMD, we cannot see any signal of dystrophy. Compared to here, we cannot see any signal along the muscle membrane. This shows that DMD suffers from dystrophin deficiency. So, what happened to Becker muscular dystrophy, BMD? So, BMD is clinically different from DMD. DMD is identified adult, not child. So, it's called the adult onset progressive muscular dystrophy. So in that case, the patient has an exon deletion as DMD. And what happened to the dystrophy? Here. This immunostaining pattern was obtained from BMD, just DMD. So there are clear difference. DMD patients show the positive signal for dystrophy. But if you see this slide, you cannot identify the difference between these two. Can you differentiate? No. It looks same. but there is a difference. so see here, no dystrophin is present, and some this is very highly stained. In that way, we say patchy staining dystrophin is observed in the BMD. So that's why the BMD patient is mild compared to the DMD, because they can produce dystrophin. But this dystrophin is abnormal, not normal. So based on the previous finding, we propose a treatment. Anyway, before talking about our treatment, I summarize the treatment for Duchenne muscular dystrophy. At first, I'd like to say the pathology of Duchenne muscular dystrophy. As I mentioned, the cause is mutation in the dystrophin gene, DMD gene. This mutation is transferred to mRNA, and the mRNA has error. And because of mutation, dystrophin deficiency is induced, and this causes muscular atrophy. This is the pathology of DMD. Every patient follows this process. So we can propose a therapy for DMD against every step. So at the beginning, when the gene is cloned, everybody believes it's easy to treat the patient by gene therapy. Nobody against that. But after 30 years, we don't do the gene therapy for DMD patient. But it's possible to do gene therapy to complete therapy, as a term, complete therapy. Gene therapy or cell therapy both induce a normal gene into the patient. Next one is exon skipping. So we propose this treatment. So I will explain this later. So just modify mRNA. And in addition, we can use the method read through. This is very difficult. And I have a question to you. What's the meaning of nonsense mutation? Nonsense mutation. Shimya? Okay. No.
The mutation doesn't change
That's in the protein means the missense mutation. Missense mutation change the one amino acid to another amino acid. Nonsense mutation change one amino acid to stop codon. So nonsense mutation create the red signal to stop the protein synthesis. So as I mentioned, some patients have their nonsense mutation. So this treatment, applied to treat the nonsense mutation. Why? How? So this drug suppress red signals. So enhance the violation of the rule to stop. Lead through the red signal to produce the protein. This is one strategy. And all of these are aiming to express dystrophy because dystrophy deficiency is a fundamental defect in DMD. In addition to this, there are another way to modify clinical phenotype. One strategy is to express eutrophin. Eutrophin is a protein similar to dystrophin. So if we express eutrophin higher, they may compensate the function of dystrophin. So this is one strategy. And from dystrophin deficiency to muscle atrophy, we think that there must be important inflammatory reaction. So anti-inflammatory drugs could work to suppress the progression of muscle atrophy. So there are many studies on this anti-inflammatory drugs. And at last, anti-myostatin therapy is now on study. You don't know the name of the myostatin. Myostatin is a very important molecule. Suppress muscular hypertrophy. This suppress the muscle hypertrophy. So if we inhibit the function of myostatin, must grow up. This is one of the treatment for the DMD patient. And as you can expect that, if we use this anti-myostatin for athlete, they can have very big muscle and win the gold medal. So many studies about anti-myostatin. So maybe from that field, very nice drug may be created. Anyway, from now on, I would like to talk about exon skipping. This is the cartoon prepared for the patient because all patients are child. So I must prepare the cartoon to explain what is exon skipping therapy. So, I described a train, very long train, but consists of 79 cars that stand for 79 exons. Right? So DMD gene consists of 79 exons. So this is in short. So normally the gene can run well, consists of 79 exons. But in the case of DMD, as I mentioned, exon deletion is a common mutation. So, curve deleted from the normal here. In the case of usual train, nothing happened even though the one car disappeared. But in the case of cDNA, mRNA, the junction between exon differ from exon. So in this case, the junction is not smooth. is not connected by deleting this exon, this kind. This occurs in the mRNA. So in this case, the train cannot run. The mRNA cannot produce protein. Right? For this, we delete additional exon by exon skipping. Remove neighboring exon from here. So outcome here. So the train can run again. But the size is short compared to the normal. But can run. That means that mRNA starts to produce protein, dystrophin. So by this mechanism, DMD patient can convert into BMD patient. All the BMD Becker muscular dystrophy patient has the mutation like this one. They produce shorter dystrophy. So our aim to convert DMD patient to the BMD patient at this moment. Any question? So this strategy was invented by identifying the mutation named Dystrophin Kobe. Please remember Kobe. So we identify one patient having this mutation. So this patient has a very small mutation in exon 19. But this is a case of the AAD. He has this mutation, and we analyze the mRNA. He showed the exon 19 skipping. Because of that small deletion here. Because of this mutation, all exon 19 disappear from mRNA. So we think that this sequence is very important for proper splicing. Splicing means the removal of introns from pre-mRNA. It's complicated. But I just remember exon skipping, name of the exon skipping. Okay. So we designed antisense against splicing and cancer sequence exon 19. And this worked to induce exon 19 skipping. So antisense oligonucleotides transfected into the cell. And after that, we analyzed mRNA. So before, only normal mRNA was obtained. But after 12 hours of incubation, exon 19 disappeared from mRNA. So this indicates we can artificially induce exon deletion. That means remove the card from mRNA. So why I think that this anti-nucleotide, we propose a treatment of DMD patient. One example of treatment is shown here. In the case of DMD patient having deletion of exon 20, he has no dystrophy. However, if we induce the exon 90 skipping, so both exon 90 and 20 disappear, then dystrophin can be produced. This difference comes from the number of the nucleotides encoded in exon 20. So, exon 20 encodes 242 nucleotides. please divide number 3. This is not divided. That induces leading frame and no dystrophin produced. But in the case of 2 exon deletion, the nucleotide encoded at 2 exon become 330. 330 can be divided by number 3. So this is E frame mRNA can produce triggered dystrophin. And we searched for the patient having a deletion of exon 20 and identified one patient in Japan and treated that patient with antisense oligonucleotides and successfully induced exon 19 skipping in the patient. And we reported this treatment can be a treatment of DMD patients. So this slide shows the picture. Look at the meeting in Monaco. At that time, when the 2004, we are the most advanced step. But after this meeting, both Professor Van Ome and Will Woodington started the study on to this exon therapy, and they started treatment, international treatment to induce exon 51 skipping using 5 or messenger RNA or oligonucleotides. And they finished the clinical trial in the world. But the FDA rejected one, which is bad news. But good news is this intravenous was approved by FDA. So now, in the world, that drug to treat DMD is available. But that can be applied for limited cases. Instead, in Japan, we use this DNA monomer, this modified nucleic acid. This is the original from Japan. So by using this DNA as a monomer, we designed one antisense oligonucleotide that induce exon 45 skipping. So this remove exon 45 from mRNA. And we are now in the clinical trial conducted by the Daiichi company. And before, a phase 1 study was conducted, but this study was completed. And we reported a result of this clinical trial in International Congress of Neuromuscular Diseases and OTS meeting. So our result clearly indicate exon skipping can be induced in the patient, in all patients treated with the antisense oligonucleotide. And in the future, we will show you the expression of dystrophin in all patients. In this way, DMD is now transformed into the treatable disease, not untreatable. Maybe in the near future, every patient will obtain the proper drug to be treated by the patient. So I hope this happen within 10 years, within 5 years. So every patient should be treated properly before starting the fundamental treatment. Thank you for attention. This is the end of my talk. Thank you.